Hi, everyone, and welcome. So this is going to be a two-part series on refractory ventricular fibrillation and ventricular tachycardia in the setting of cardiac arrest. On part one, we're going to be focusing on pharmacology, so all of the medications that you need to consider when managing these patients. And part two is going to focus a little bit more on procedures. So before we get into talking about medications, I want to emphasize that this lecture is not on electrical storm. So electrical storm is defined as 3 or more episodes of recurrent ventricular tachycardia, ventricular fibrillation in the span of 24 hours. In these scenarios, patients actually revert back to sinus rhythm very easily with defibrillation. On the other hand, patients in refractory ventricular tachycardia, ventricular fibrillation are actually going to be persistently in this aberrant rhythm despite the administration of defibrillation and despite receiving an initial antiarrhythmic. Unlike electrical storm, patients in refractory VT/VF are never going to go back to sinus rhythm. So unfortunately, much of the evidence that we have up to now shows that the use of antiarrhythmics in refractory VT/VF is not very useful. It hasn't really shown any benefit in terms of mortality. There is potentially an improvement in mortality in those patients with witnessed arrest. However, it's unclear whether or not this is the antiarrhythmic at work, or if it's just because the patient had a witness collapse and received bystander CPR. Regardless, there are medications that we have available to us and we should consider when managing these patients. So your first-line antiarrhythmic here is going to be amiodarone. So amiodarone is a class 3 antiarrhythmic that will block your beta receptors as well as your calcium and sodium channels. The initial bolus in cardiac arrest is going to be 300 milligrams, followed by repeat boluses of 150 milligrams as needed. And if you obtain ROSC, then you could put the patient on an infusion. Now, a quick word here on procainamide. So procainamide has gained a lot of favor recently. It's become more popular. It's being used more often. But in the setting of cardiac arrest, procainamide is probably not the best option. And the reason is because procainamide takes a very long time to actually get an appropriate loading dose. So the loading dose is about 10 to 17 milligrams per kilogram, which can be infused over the span of 20 to 30 minutes. We can also give procainamide as boluses of 150 milligrams every 5 minutes. So in a standard 70 kilo adult, you can think that it's going to take about 35 to 40 minutes to get to that appropriate loading dose. So this is not feasible in cardiac arrest. The next medication to consider is a beta blocker. So a beta blocker is going to blunt that adrenergic surge. It's going to blunt the central nervous sympathetic drive that is causing these recurrent ventricular arrhythmias. The two agents to consider here are propranolol and esmolol. So propranolol is potentially a little bit better as it has both beta 1 and beta 2 properties. In cardiac arrest, you can initiate an IV bolus of 1 to 3 milligrams, and you can give it about every 5 minutes. The max dose here is going to be 5 milligrams. So once you've achieved an adequate response or you've reached your max dose of 5 milligrams, you don't want to give any additional boluses of propranolol in order to avoid any adverse effects. The other agent to consider is esmolol. So esmolol mechanistically might not be as good as propranolol as it is beta 1 selective, but the great thing about this medication is its titratability. So esmolol is very fast on, very fast off. You can initiate with a bolus of 500 micrograms per kilogram, followed by an infusion of 50 to 300 micrograms per kilogram. If you don't have either of these medications available to you, you can also consider metoprolol. It's not as effective as these two agents, but again, if you don't have anything else available, metoprolol can be administered. A good second-line antiarrhythmic is lidocaine. So a lidocaine can be given at a bolus of 1 to 1.5 milligrams per kilogram and a repeat dose of half of what you initially gave. So in a standard 70 kilo adult, I typically give a 100 milligram bolus initially, followed by 50 milligrams. If you obtain ROSC, you can again put these patients on an infusion. And two scenarios where lidocaine might actually be the first-line antiarrhythmic is in patients with acute cardiac ischemia. So we've found that patients who receive lidocaine actually respond better when their myocardium is injured. And in the second scenario, where lidocaine might actually be the first-line medication, is in Torsades, because lidocaine can actually shorten your QT interval. Magnesium supplementation is also something that I give up front very frequently in patients with ventricular arrhythmias. Remember that hypomagnesemia can increase your QT interval. It can put you at higher risk for arrhythmias. So giving 2 grams of IV magnesium sulfate up front is definitely very reasonable to do. If you're concerned for Torsades or treating Torsades, you want to give a higher dose of 4 grams, followed by an infusion. If you obtain ROSC, then you also want to treat potassium very aggressively, right? So patients with hypokalemia are typically also hypomagnesemic, so be aggressive with electrolyte repletion. And then in terms of a magnesium level, you want to stay at around 2.2 to 2.5 in order to prevent recurrent arrhythmias. If you've been successful in obtaining a pulse during your resuscitation, your patient is going to be intubated, they're going to be on mechanical ventilation. So you want to make sure that they are appropriately sedated, that they receive the appropriate pain medication. Remember that pain, anxiety, agitation, all is going to increase your sympathetic tone, going to cause a huge catecholamine surge. So being aggressive with medications to control this is very important to prevent your patient from going back into ventricular arrhythmia. In terms of hemodynamic support, you want to keep your patient's MAP greater than 65. And equally as important, you want to keep their diastolic pressure greater than 30. So remember that the diastolic pressure is what perfuses your coronary arteries. So keeping this pressure above 30 is going to perfuse that injured myocardium. Remember that ischemic myocardium is arrhythmogenic. In terms of vasopressors, phenylephrine is probably the best option as it's a pure alpha agent. However, norepinephrine is also a good agent to use as it has more alpha than beta properties. And then remember to limit your epinephrine dosing. So these are the patients where I would not be putting them on a long-term epinephrine infusion. And in cardiac arrest, I typically spread out my epinephrine doses to every 5 minutes. You'll still be, following ACLS protocols. You'll still be within standard of care, but by spreading that out to every 5 minutes, you're going to be giving less epinephrine. And then also consider special cases. So we talked about Torsades. So Torsades typically responds better to magnesium as well as lidocaine. And in patients with Brugada pattern who develop ventricular arrhythmias, you want to consider isoproterenol or quinidine. So it might be a little counterintuitive to say, hey, let's give this patient isoproterenol when they're in the rapid ventricular arrhythmia. But the thought is that patients with Brugada syndrome have an increased vagal tone. And by giving isoproterenol, you're actually going to be increasing that sympathetic drive, which will change or get rid of those ST segment abnormalities in your anterior leads, thereby preventing recurrent arrhythmias from occurring. All right, and to wrap things up, so when giving medications in refractory ventricular tachycardia, ventricular fibrillation, your first-line antiarrhythmic of choice is going to be Amiodarone, followed by a supplementation of magnesium. A second agent to consider is going to be a beta blocker, such as propranolol or esmolol. And then your second-line antiarrhythmic is going to be lidocaine. And remember that lidocaine may actually be your first-line medication in the setting of acute coronary ischemia or Torsades. If you obtain ROSC, remember to replete your electrolytes aggressively, provide adequate analgesia sedation, provide hemodynamic support with an agent that has more alpha than beta, and then consider special circumstances such as Brugada syndrome.